I'd like to bring up Kristen Bowker. She is going to be the MC for this particular section of the program as we focus now on cobalt, use of cholic acid in SLOS. Ladies and gentlemen, here is Kristen Bowker. Kristen.
Thank you so much. I'm really excited to start this next session with you all. But before we get started, I just want to introduce myself a little bit and let you know what you can expect over the next 90 minutes or so. My name is Kristen Bowker. I'm from Mirum Pharmaceuticals. And my role at Mirum is really to develop patient and caregiver resources for families and information. And it's very near and dear to my heart because 12 years ago, my daughter was actually diagnosed with a rare genetic disorder, and it was actually a patient event just like this for my daughter's disease that I attended that really sparked my interest into advocacy and learning more. So I think someone said it the other night, you'll never forget your first conference, and I definitely do not forget my first conference. It really meant a lot to me. So it's just so special to be here with you guys, and I just want to thank the SLOS Foundation for having us and being a part of it. It's just been so fantastic. So I want to next just introduce some presenters. We're going to have quite a few presenters. We'll have 4 different folks up here. We'll have the first 2 presenters be physicians. So I'm going to go to the next slide. There we go. So we have Dr. Joe Ray and Dr. Clay Farron. Dr. Joe Ray is actually Zooming in, so he will join by Zoom, but Dr. Clay Farron is here. Dr. Clay Farron is a pediatric medical geneticist at Atrium Health in Charlotte, North Carolina. And Dr. Joe Ray is the chief of the medical genetics and metabolism at the University of Texas Medical. Both of these physicians are fantastic advocates for rare disease and serving their patients and for SLOS. And speaking of that, Dr. Clay Farron is the physician for the Weaver family. Many of you guys know Taylor and James Weaver and their daughter Mally and her cute face you've seen at our table out there. So he will be speaking to that experience, and the Weavers will also share their experience. So they are going to come up and share their experience about SLOS and their experience with cobalt. And afterwards, we'll have some time for Q&A. You guys will notice there's some cards at the center of your table. If you, as you're hearing the presentations, want to jot down a question, feel free to write it down, flag me, and I'll ask it, or if you'd like to come up to the microphone if we have some time. So without further ado, I'm going to go ahead and have Dr. Farron come on up. If you would give him a warm welcome, please. I'm just going to go have you jump right in.
Perfect. Sounds good. Well, thank you all for having me today. I appreciate the time to be able to speak with y'all. And hi, Mally. Perfect. So we'll get through the boring stuff real quick first, but this presentation was developed by Mirum Pharmaceuticals. All speakers are presenting on their behalf. Both Dr. Ray and I are being compensated for our presentation today. And then information regarding, consistent with the full prescribing information of cobalt is available after the accompanying this presentation. So what I'd like to do today is take some time and really talk about the importance of healthy cholesterol and bile acids and kind of set things up. The opening act, as they would say, for the big show with Ms. Mally coming later. But really talking about cholesterol. And most of the time when we think about cholesterol, we think of all the bad things that it can do. As far as, we're worried about our heart risk with cholesterol, but cholesterol in and of itself plays a very big and important role in our body. And so it's responsible for, becoming building blocks for cells. It's an integral part of cell membranes. It's a precursor to many of our hormones that we use, our body uses to communicate. It's important in brain health, as it makes up a lot of our an important component of cell membranes in our brain. We'll spend a lot of time talking about bile acid production today and cholesterol's role in that. And then also, as you know, bile acids are important for how we absorb fats and fat-soluble vitamins from our diet, plays an important role in our growth and development. So looking at cholesterol and bile acid production, so cholesterol and bile acids are made in the body through a series of chemical steps. In SLOS, the DHCR7 gene is not performing correctly, which leads to 1, low levels of cholesterol, 2, it can lead to harmful increases of cholesterol precursors 7 and 8 DHC. Because of this lower level of cholesterol, we also see problems with our formation of our bile acids, again, as cholesterol is a precursor to our bile acids. We also get the production of harmful byproducts called oxysterols that can affect cognition and behavior, and other potential outcomes such as increased risk for infections and poor growth all run with this condition. And so here we can see the block here of just representing that DHCR7 with that increase in 7-DHC and 8-DHC, leading to decreased cholesterol production and decreased production of our primary bile acids, which cholic acid is one of them, as well as chenodeoxycholic acid as well. And those are our 2 primary bile acids that our body makes. I do want to spend some time talking about cholesterol as well and kind of how it's tested for. And so typically when we think of doing a cholesterol test, it's kind of like our standard lipid panel. And some of the problems that we can have when measuring this in our families and our friends with SLOS is that it doesn't give us a great representation of true total cholesterol. And the reason for that is that cholesterol that we get measured on a standard test will also pick up these precursors 7 and 8 DHC and can give us a false elevation of what our true total cholesterol is. There are specialized cholesterol lab tests, and we'll kind of talk, I'll show a photo on the next slide, that do differentiate this and pull out the total cholesterol as well as the precursor 7 and 8 DHC to give us a better understanding of what the true
Recording in progress.
Got it. They missed that whole first part. I will not repeat. And so, but the allows us to differentiate out those precursors and get us a better understanding of the total cholesterol. And so there is a test called the SLS cholesterol and 7,8-DHC intermediates test. This is something I send on all of my friends when we have every visit. And this test is offered through Kennedy Krieger, sponsored by Miram, and allows us to be able to monitor the precursor 7 and 8 DHC, as well as get a better understanding of the total cholesterol because it accounts for those. So looking at potential nutritional challenges and solutions in SLOS. So again, as we've been talking about, bile acids are really important. So they're responsible for helping digest and absorb nutrients from food such as cholesterol, fats, and fat-soluble vitamins. They help us maintain healthy liver enzymes. People with SLS, we know, have low bile acids, and that's a result of that decrease in cholesterol production. Without enough bile acids, we know it's difficult for patients to absorb cholesterol and other essential nutrients properly. And one important type of bile acid, as we talked about, is cholic acid. It's one of our primary bile acids. It makes up a huge percentage of the bile acids that we make in our body. So again, as we're kind of going over this again, people with SLS, low levels of cholic acid can make it harder for the body to absorb cholesterol from supplements or food. And so potential feeding and nutritional challenges and solutions that we have in people with SLS. So a lot of our friends need help with feeding, usually through a G-tube or NG-tube, to try to make sure we're getting the appropriate amount of nutrition. And we also have another way to supplement that nutrition is through cholesterol supplementation. So this can come through either through a powdered form of cholesterol that's available versus a dietary form, usually through egg yolks and other foods that are high in cholesterol, or a combination of the two. And then we also have antioxidant supplementation that's being looked at, I believe, in Colorado with vitamin E. And then we have now kind of what Dr. Ray's going to be talking about here in just a minute, cholic acid treatment, or supplementing those bile acids that are not able to form in appropriate levels as a result of this condition. Perfect. And with that, I'll pass it on to Dr. Joe Ray, and he can talk about the use of Cholbam and SLOS. You there, Joe?
Mute myself. There we go. I'm able to mute myself now.
Don't worry, the recording is working now, so they will get everything that you said.
They get all the technical difficulties. Excellent. So sorry I couldn't be there in person, everyone. Had some life stuff come up and it made travel to the area difficult for me, but I'm glad I had the opportunity to talk to you a little bit about my experience in this area. So I started treating patients with SLOS when I was in training, and then had my own patient with SLOS actually within the first few days of me taking over the chief position here at UTMB. So I'm going to talk to you about this medication Cholbam or cholic acid and my experience in the use of SLOS. And I'll start off by just giving you some detail about it. So what is it? So it's a capsule form of cholic acid, which is a type of bile acid or a part of the bile acid mix-up. And it's used for treating all patients with bile acid synthesis disorders. And so what is a bile acid synthesis disorder? It's a condition where a person is missing an enzyme or a protein that helps produce all the different precursors that make up our bile acids. And Smith-Lemli-Opitz falls into that category. So the DHCR7 gene codes for our ability to convert 7-dehydrocholesterol into total cholesterol, and then the total cholesterol is then taken through a number of steps to create our bile acid. And one of the areas that we're deficient in is cholic acid. And so how does it help? It increases the overall amount of cholic acid, which then increases the body's ability to produce the additional parts of the bile acid for the patient. The way that we've seen it help in our patients is that it's increased total cholesterol levels, which has been really kind of the main thing that we've chased for the majority of the time that I've taken care of patients for SLOS. But it's also helped improve their growth, so helping them move higher up on the growth curve on the SLOS growth curve or even a CBC growth curve, and then lower the overall inflammation that we see in the liver as it relates to having a bile acid synthesis disorder, so lowering the liver enzymes. It has a well-established safety profile. It is an oral medication, so the most common side effects that we see in these patients is GI related. So we see things like diarrhea most often, and any amount of patients that experience the side effects, it's only about 2%. So it has a very, very good safety profile. It's very, very well tolerated in our patients. Now, because we're dealing with bile acids and we're dealing with liver inflammation, there have been cases where we've seen some increased irritation of the liver by manipulating the bile acids with a medication like this. That's seen in a very small percentage of the patients, but the overall kind of clinical outcome when we see those side effects are the same things that we would see if the liver is being inflamed, and that would be yellowing of the skin due to bilirubin being deposited in our skin, darkening of the urine, same compound that's going in there, pain in the area of the liver, and then potential abnormalities in our coagulation ability for our blood. So that would result in things like easy bruising or prolongating, things like that. Now seen in about 1% of cases. So how do you know if your child might be eligible or might benefit from the use of Cholbam? You can answer one of these 3 questions, and if you answer yes to any of those, then Cholbam might be good for you or good for your child. So does my child have lower than normal cholesterol levels? Most SLOS patients do. Do they struggle to grow on schedule? And do they have higher than normal liver enzymes? So is Cholbam studied in people with SLS? So there has been a very short-term study done called the ELIAS study. This was a study that looked at 12 patients with Smith-Lemli-Opitz and then an additional 8 real-world patients that were looked at retrospectively, meaning that we just reviewed their charts while they're on this. That has given us an idea on how this is helpful in this patient population. So in the pilot study or the ELISE study where we looked at those 12 patients, all these patients had cholesterol levels that were under 125 milligrams per deciliter, so less than normal. And 11 of the 12 patients were on cholesterol supplementation, kind of the standard of practice for SLOS. And in the study, what they were looking at were cholesterol levels as well as some of the derivatives, the 7-dehydro and 8-dehydro cholesterol levels, the harmful oxysterols that Dr. Farron mentioned, changes in body weight, and then, of course, the safety profile for them. And the end results of that study, we saw that there was an increase in their total cholesterol. We saw a positive trend increase in their weight, as well as a decreased trend in those oxysterols. But as far as the derivatives, 7-dehydro and 8-dehydro cholesterol, it was a very short-term study, about 2 months, and so we didn't see any changes in those. Looking at our retrospective study where we looked at those 8 patients over time, the time for those patients were anywhere between 30 days on medication to 450 days on medication. And similarly, what we were looking at was the same kind of data that we were looking at in the ELISE studies, so tracking height, weight, and other body measurements, as well as some of those lab results like cholesterol levels and 7-dehydro cholesterol levels, and then, of course, any documented side effects as it relates to cholbam. And reviewing that data, we saw that patients had, before they started on the medication, they had low cholesterols and high levels of harmful precursors, and their growth was below average. So very kind of following the trend that we see in the SLOS population. And the end result was very similar to what we saw in our pilot study. So we saw improvement in their total cholesterol levels in 7 out of the 8 patients. We saw improvement in their growth parameters. And then as far as adverse effects that we've seen, one patient had a transient color change in their fingers and toes, and we weren't able to determine whether or not that was related to cholbam or another event that was going on in the patient. So overall, and mirroring the data that we had in the last study. Which brings me to my own real world experience. So I wanted to talk a little bit about my kiddo. So this kiddo we call Guapo. This is a name that he kind of came up with on his own, and everybody just kind of took to it. So this young man was actually presented to me at two days of age. I was asked to come by the neonatal ICU on my very first day on inpatient service to evaluate this child. And he basically read the book for Smith-Lemli-Opitz. I took one look at him and I told everybody in the NICU that this guy has Smith-Lemli-Opitz. He had all the kind of physical findings that we would see in this condition, including the webbed toes or toothed toes and maxillary. He had kind of the facial structures that are similar from SLOS patients. He had poor feeding, he had a heart defect, he had abnormalities with his GU area, and then extra fingers and extra toes. So he very much looked like a Smith-Lemli-Opitz patient. And so we sent off some testing and got that confirmatory testing back at 1 week of age, and we were able to establish the diagnosis of Smith-Lemli-Opitz in him. While he was in the NICU, he had multiple procedures. I advised the team to talk to the family about putting in a G-tube, primarily because we know that the majority of these patients will have feeding issues and that the primary treatment is getting cholesterol on board. And so we wanted to make sure that we didn't have any barriers with getting that cholesterol on board. So he had a G-tube placed. He also had his hypospadias fixed, as well as his testes fixed while he was in the NICU. And then we started him on cholesterol supplementation as quickly as possible. As far as his growth over the next few years, it was pretty consistently low. So he followed the Smith-Lemli-Opitz established growth curve, which is about 2 or 3 standard deviations below the CDC growth curve. So he maintained that trajectory for many, many years. In May of 2023, at about 9 years of age, we were in discussions about the use of cholbam with some of our colleagues, and I approached mom with the data that we had available about utilizing cholbam and asked if she wanted to give it a try, and she was on board. At that point in time, she had a very good understanding of the metabolic processes that were going on in this condition and why we were giving Guapo cholesterol supplementation. but she also had a very good like realization that no matter how much cholesterol we threw at him, his cholesterol levels never really normalized. And being a Hispanic family, they're very interested in getting him to grow and gain weight, and that was just a constant struggle. So mom was very motivated at the data of seeing some of these patients increase in weight, and so was willing to give it a try, particularly because the side effect profile seems so favorable. And so his height and his weight at the time, I use the CDC growth curves here to kind of show you where he was at. So he was at the 4% on the CDC growth curve for his height, and he was at the 0.5% on the CDC growth curve for weight. So very, very, very underweight. Since he started on treatment, we started to see very significant effects for him. So first for him, he didn't have any really side effects. So in the very beginning, there was a little bit of maybe nausea that mom reported, but none of the side effects that we saw in the clinical trials, like the diarrhea and the potential liver inflammation. And so at about 10 years of age, his height and weight really blew us away. He went from, like I said, following the traditional growth curve for Smith-Lemli-Opitz to jumping up and being completely normal in weight on the CDC growth charts. So at 10 years of age, he was at 40th percentile for the CDC growth chart. So he had jumped multiple standard deviations off of the Smith-Lemli-Opitz growth chart into the CDC growth chart. And then his height also increased. He was within the normal range on the CDC growth chart as well, so 9.15%. Other things that we noticed that we weren't expecting were mom was starting to notice some cognitive changes in him. His language at 9 years of age was pretty limited. I couldn't ask him the normal questions that I would ask kiddos, like, hey, what do you want to be when you grow up? Or, what do you want for Christmas? And those kinds of things. And his sentences were closer to like two-word sentences. But what mom reported to me was that he started adding on more words to his sentences, so building more complex sentence structures, and really started to be able to convey or answer questions, complex questions, like what do you want to be when you grow up, more coherently after being on the treatment for about a year. In addition, he was in a dual language household, and his sister, who is several years younger than he is, was starting to try to make that transition of segregating Spanish language from English language. And really one of the things that brought mom to tears is that was the first time that she ever saw Wapo being a big brother to his sister, is when she started noticing him trying to correct her and teach her the difference between Spanish words and English words, which was kind of a big deal for the whole family, and very much a big deal for me because I'd never seen him do something like that before. Mom also noticed that he had improved appetite, obviously, because his weight increased quite a bit. And even his teachers were noticing that his interaction with his peers and his performance in school were improving. So not something that we saw in the studies, and not something that we were expecting or even conveyed to the family when we started them on this treatment. But it was kind of a nice surprise. So here's some physical data on what we saw. Looking at his baseline, you can see that his weight was quite low. And then over the course of 150 days, he just shot up really rapidly, so jumping several standard deviations up to this level. His total cholesterol has always been under normal, and we saw a steady increase in his total cholesterol level over the 150 days, getting really close to that normal level of 125 milligrams per deciliter. In addition to that, his height started to follow suit. So as his weight started to increase, you can see that his height is increasing along with that. And again, he's now on the normal growth curves for the CDC growth curves for both of those things. And then his ALT and AST, which we used as representative of whether or not he had ongoing inflammation in his liver, you see that his ALT trended down quite a bit, while his AST stayed relatively stable. So how is this medication taken? Well, the most common dosages are between 10 and 15 milligrams per kilogram. So it's weight-based medication, and it's taken oral. It's taken by the mouth either once daily, or it can be divided into 2 doses if it's like a really big dose and we're having trouble with that. The majority of physicians that start the patient on these medications start them at 10 milligrams per deciliter, or 10 milligrams per kilogram, but we have some wiggle room because approval has been approved for up to 15 milligrams per kilogram. So as far as what is the best dose for your kiddo, that's definitely going to be kind of a tailored approach that you and your doctor will come up with. The most important thing to note is that we'd like for people to take Cholbam with food because it does have a little bit of irritation of the gut. Remember, a small percentage of them can develop diarrhea. So taking it with food will help with that. It will also help with the absorption process. I see a question pop up. Nikki says, we have noticed after only a few months of using Cholbam, less irritability, better sleep and rest, better receptive awareness. Seen at age 25 in the arts. Okay. I don't know if everybody's able to see the chat, so I'll just read it out to everybody as it comes to me. So as far as patients who are unable to swallow, so the most important thing is to not crush or to chew the capsules, but you can open up the capsules and mix the content with food and drink. So there is a way of getting the medication on board if the patient can't swallow. It doesn't taste very good. Again, it's cholic acid, it's a bile acid. And so if you are in a situation where you have to mix the contents with food or drink, you can use some masking things like syrup, maple syrup, coffee creamers, things that have strong taste to mask the kind of basic taste of this medication. As far as timing, take at least 1 hour before or 4 to 6 hours after taking a bile acid binding resin or some sort of antacid. So if there are other medications that your child is on, you know, make sure that your doctor knows about those things. And if those medications happen to be a bile acid binding resin or a antacid of some sort, then discussing the timing on when you can take that medication with your doctor so that everybody's on the same page. Raul Sanchez says, my daughter is 34 and a severe case of SLO. Do you think Cholbam would be benefit for her? So yes, I do. I think all patients would benefit from the use of Cholbam. You know, I know that your daughter is 34 and has lived most of her life with, you know, this bile acid synthesis disorder. But correcting bile acids, there's not like a timeline on when we would no longer do that. So your daughter, although has been kind of reached the upper end of weight gain and, you know, neurological development and things like that, you know, cholesterol plays a very important role inside of our system, and not being able to convert 7-dehydrocholesterol cholesterol into total cholesterol and having a very low amount of cholesterol for most of your life is detrimental throughout your life. And so it's the reason why even in our 34-year-old cases, we're still supplementing them with cholesterol. And so giving the patient Cholbam and giving them the opportunity to get their cholesterol levels up higher, you know, cholesterol doesn't just get converted into bile acids, it gets converted into hormones, neurotransmitters, and other things that are deficient in these cases. And so increasing those resources, even for an adult patient, will probably be beneficial. Jalen Drath says, if weight gain has been consistent on CDC chart, but cholesterol and DHC7 is high, would you still consider your Cholbam for treatment? And our daughter was 9 months old. Great question. So that answers the one of the 3 questions earlier that we mentioned in the presentation. So is your child not gaining weight? If you said yes, then that would qualify them for this medication. If their cholesterol has always been low, then that will qualify for them for this medication. So in this particular scenario, because the cholesterol, I think the cholesterol and DH7 is high. So both total cholesterol, if you want to clarify for me, Jalen, both total cholesterol and 7-dehydrocholesterol are high? Or did you mean to say total cholesterol was low? because that would be unusual to have elevated 7-dehydro and elevated total cholesterol since you're converting 7-dehydro. Cholesterol is low. Okay, yeah. So because cholesterol is low, Cholbam would be helpful for that. Because I'll show you, moving back my slide here, that up until we started the patient on Cholbam, cholesterol had always been pretty abysmally low. Getting him above 100 right here was like pounding him with like 3 or 4 egg yolks a day. Whereas keeping him on 2 to 3 egg yolks per day and adding Cholbam, you can see that we were able to get his cholesterol level up close to 120, so getting it very close to 90. So yeah, I think that your 9-monther would benefit from Cholbam. Let's see. Priscilla said, my son has been on it since 5'1". He has lost 2 pounds and had very loose stools and diarrhea since then. Is that something that can be expected to improve? Yes, but I would try to investigate why he's having the diarrhea. So is the diarrhea related to the medication, or is there something else going on that is causing the loose stools? Because if he's having rapid loss of stool, he may not be absorbing all of the medication. So I would revisit with your physician and try to figure out why that is an issue. Now, I will say that the diarrhea that's associated with using Cholbam does resolve with time. So it might be that your child might need some additional help if they are experiencing side effects as it relates to Cholbam in the form of some antidiuretics until those side effects do resolve. Nikki says, I should have added that Gina is considered severe SLO, and although we had to go through about a month of loose stools, that has subsided and overall Gina appears to be feeling more comfortable. And that was in regards to our 25-year-old mentioned earlier. We no longer use Miralax. Okay, keep asking questions. This is great. I think that we can make it a very dynamic conversation. So I'll just keep this chat box open so I can follow along with those. Okay, so how do we get our patients access to Cholbam? And so I wanted to spend a little bit of time with Mirum Access because these kinds of programs are kind of the bread and butter of why our rare disease pharmaceutical programs actually work. So the purpose of Mirum Access panel is to support not just your provider, but also you to make sure that there's not a barrier financially for your child to get access or for your family member to get access to Cholbam. And so Mirum works very closely with the provider as well as the patient to assist with making sure that there's insurance coverage, and then to discuss financial support options and eligibility so that whenever your physician and you decide to start your family member on this medication, that finances is not going to be the one thing that causes us to not be able to treat your family member. Another question popped up. So Jessica says, our son Riley has been on Cholbam for approximately 2 years. His total cholesterol elevated, height and weight increased significantly. He's considered nonverbal, however, very vocal. His attempt at creating words has increased. His appropriate cognitive engagement has increased. He is G2 fed, no side effects, and Mirum has been invaluable with checking. So thank you for sharing that with us, Jessica. That is really, really good stuff to hear. I feel like my experience with this treatment has been very similar to yours as well. So all things moving in a positive direction. Specifically, some of those cognitive things that are really hard to kind of capture quantitatively, but the families notice it. And that's the main thing that I try to convey to my colleagues is that I can't give you quantitative trajectory of what we're seeing with the use of the medication, but the families notice that cognitively the patients are improving, whether it be through increased amounts of words or increased amounts of reception to words and things like that. So same things that you're reporting as well. And this is just more information about getting enrolled in Mirum Access Plus. So I can certainly come back to this slide so that we have that information, or I imagine my colleagues there have this information for you and your providers to be able to have access to the Mirum Access Plus. So just kind of going through Cholbam one more time before I pass it on to my colleagues there. So Cholbam is an oral medication. It's a cholic acid medication that helps your body increase the amount of bile acid production that you have. It's primarily designed for treating bile acid synthesis disorders, and Smith-Lemli-Opitz is one of those conditions. It falls into the bile acid synthesis disorder because you're unable to produce total cholesterol, which plays a significant role in creating bile acids. As far as whether or not you think it might be right for you and your family member, I'll dial back to what I said earlier. If you have low cholesterol, then it would probably be beneficial. If you're not following a traditional growth curve or having trouble gaining weight, probably beneficial as well. Couple things to note. If you're pregnant or become pregnant, or you're breastfeeding, that there's not a lot of safety data for those particular things. There's also the potential for a severe side effect. As I mentioned it earlier, in 1% of the cases, patients may have increased liver inflammation with this medication. And so making sure that we're following liver enzymes in these patients so that we're able to address the potential for increased liver inflammation. Now, some of the side effects or physical things that we'll see if a person has liver inflammation is color changes. So we can see yellowing of the skin, darkening of the urine, as well as complaints of pain in the right side of the body, and then increased bruising. Phelan asks, is there a way to test bile acid levels prior to starting the medication? Yes, you can. So you can test bile acid levels. It's not a traditional thing that we do. I, as a medical geneticist, I don't usually test bile acids in patients, but I know that that's something some of my GI colleagues do on a regular basis. As far as the most common side effects that are associated with this medication, again, they're mainly GI related. So diarrhea, as some of our attendees have reported in their own family members, but also patients can complain about upset stomach as well as nausea. So just to summarize, people with Smith-Lemli-Opitz, they have what we call an autosomal recessive condition where they have a broken DHC7 gene, and they inherited one copy of that from mom and one copy of that from dad. And the end result is an enzyme deficiency that makes it difficult for them to convert 7-dehydrocholesterol into total cholesterol. And so these patients not having a lot of total cholesterol are unable to produce an adequate amount of bile acid. And a lot of the growth issues, feeding issues, and things like that we see in these patients are directly result from that. In addition, they had an increased production of some of those oxysterols, those kind of very difficult toxic cholesterol compounds, and those can have negative effects on development and learning. Cholbam is a prescription that's called cholic acid. It's a cholic acid replacement, and it helps patients with bile acid synthesis disorders like Smith-Lemli-Opitz produce more bile acid. And the end result that we've seen with patients that utilize this medication is an increase in their cholesterol, as well as an improvement in their overall growth and a lowering of liver inflammation. I think that is it from my part, and I will pass it on.
Thank you so
To
much. If you
our
want to give a
patient speakers.
round of applause to Dr. Joe Ray and Dr. Farron. Thank you so much. I know many of you have questions. If you don't mind holding them just for a little bit longer, I would love to have the Weavers come up and share their story, and then we'll definitely have some time for some Q&A. So we will have the Weavers share. We've got Taylor that's gonna head up first, and they're a little nervous, so we're gonna get them, like, we're gonna get the wiggles out, maybe give them a good round of applause the first time they've shared their story. Give them some good SLOS love. You guys will do great. You've got the microphone there. Yep, you're good. You don't even have to stand next to this one. Can you hear? Okay, good.
Yeah.
Great.
Hello, everyone. My name is Taylor.
And I'm James. We're Mally's parents.
Mally is a lot like other 4-year-olds. She goes to church with us, and she loves a lot of things that other little girls love. She also does clogging, and she just had a dance recital a few weeks ago. She does a lot more looking in the mirror, and she actually slept through her second song in the recital on stage.
Yeah, Mally doesn't do a lot in dance, but being around other kids and doing things that they do is very important to us. We want her to have as much of a normal childhood as she can, and we do not want society to look at her any different from any other kid.
But things are a little different for Mally because she does have SLO. We'd like to tell you how we're helping Mally live with this, and we'd like to thank Miron for sponsoring us to share our story. James and I grew up in the same small town. We met in church. We were friends for a little while before we started dating in 2013, simply because I was older than him. We got engaged in 2015, and we married in 2016.
Church is a big focus for our family. We're both big sports people, so we did a lot of sporting events together through the church. We also worked together at our family's restaurant, and she was the night shift manager.
Yes, I was his boss. We always wanted kids, but my first pregnancy in 2018 wasn't successful. So when James and I found out we were pregnant in 2020, we were pretty excited but also nervous. The anticipation up to our first ultrasound seemed like it took months, but that day we were so relieved to see our sweet baby's heartbeat. My pregnancy didn't seem hard at all, except I did have gestational diabetes, so I got pricked all the time. That changed during my 20-week anatomy scan. This was during COVID, so keep in mind I wasn't allowed to have anybody with me. I got to hear Mally's heartbeat, and the ultrasound tech showed me all her little features, which was super cute. The tech kept capturing and measuring a certain area on Mally's head. She was quiet, and I could read on her face that something was concerning. So after that, I met with the maternal fetal medicine doctor. She told me Mally had a cyst on her brain. I panicked, and I was alone, like I said, in a conference room with the doctor I had just met, and she was telling me she didn't know what kind of cyst it was or how serious it was.
When Taylor told me the news, I tried to stay calm. Deep down inside, I was freaking out. Knowing something is wrong with your baby before she's even born is bad enough, but finding out it's on the brain is a whole nother level. I was frustrated that I couldn't go with her to any of the appointments with her because of COVID. She did FaceTime me during the scans when she was able. She was alone for every one of them. I hated the unknown of what was to come, but I tried to stay strong and positive for her.
From then on out, I had scans every week to check on the cyst. It didn't get any larger, so the doctor assured me she thought everything was fine. We would just need to make an appointment with a neurologist after Mally was born. When the time came, Mally arrived super quick, and it was a pretty easy delivery. She wasn't crying when she was born. You could tell she was alive, obviously, but something was off. Her temperature was too low, and her color was not very great. They called the neonatologist, who examined her quickly, and when he got mucus out of her mouth, she started breathing better, and he said, Mally has a cleft palate. We didn't believe him at first because we thought you had to have the cleft lip as well. We actually told him that she didn't have a cleft palate, like we actually knew. I did get to hold Mally for like maybe 2 minutes. They took her to the NICU to try to get her oxygen levels up.
We were so excited when Mally came into the world, but it was nerve-wracking. She couldn't hold down food or take a bottle, so we know we needed to be transferred to a bigger hospital just a few days after being in the NICU. It was a lot to take in, so we just took it day by day. Whatever came that day, we dealt with it. We relied on each other and the help from our family.
When we transferred to the new hospital, a cleft palate oral surgeon examined her. We thought she'd have cleft palate surgery sometime that week, and that we could just take her home. When he told us cleft palate surgery wasn't performed until the baby was at least a year old, we were really devastated. But we were ready to get her home, and we would do whatever it took. The whole time Mally was in the hospital NICU, we never went home. At first, we thought everything was going fine, but when she wasn't progressing with her eating, we realized that this was becoming a bigger issue. After 2 weeks, we came to a crossroads. We asked the doctor what was stopping us from going home. The doctor gave us a choice. We could stay at the hospital until she started taking a bottle, which we would still be there today, or we could do surgery to give her a G-tube. It did break our hearts to think that our newborn was going to be put to sleep and go through surgery, but we knew that our best bet of getting home was to do that. Mally did wonderful. She recovered quickly, and she recovers quickly more than he does after surgeries. And after 20 days in the NICU, we were headed home.
When we came home, we had a hard time getting Mally to gain weight, so we were sent to different feeding specialists. The first 6 months were rough. Mally vomited all the time and had constant ear infections from the vomit that went every which way since she had the hole in her mouth. Everything we did got us nowhere. I was working at a family construction company at the time, and it was for family, so at the time it was helpful. I could take off and come in late when I needed to help Taylor get Mally ready. And Taylor worked from home, which had the flexibility to be able to get up and down in the middle of the night and feed Mally.
Finally, the day came Mally had cleft palate surgery. It was very terrifying, but she slowly got better and started eating a little bit more. There were still some complications. She developed a fistula that needed to be repaired, and if anybody don't know what that is, it's just like a hole that developed in her cleft. We did get that repaired. It took another year, but she recovered quickly from that as well, and finally started eating some baby purees. She didn't eat too much, but better than nothing. Thankfully, she was still able to get all her nutrients through her G-tube. At that time, we felt like she would grow out of everything, that she'd eat more and get a growth spurt, but she still threw up several times a day. It wasn't acid reflux, ultrasounds didn't show any problems in her stomach, and no one had a clue what was going on.
Since we weren't having much luck at all, the pediatrician recommended us to talk to a geneticist. Taylor and I were standoffish at first because in my head it felt serious, way too serious. I didn't know if we were looking at something that may be short-term, long-term, or even terminal. The fear of the unknown made me feel like I didn't even want to know. I just wanted to go on with life as it were. But I knew we couldn't do that because we needed real answers of why Mally was struggling. In September 2022, we finally went to see the geneticist. When we went for our first official visit, he examined Mally and told us he needed to do blood work, but he was 90% sure he knew what she had by looking at her physical features. That's when he told us about SOLS, and he also told us not to look it up online, and if that's what she had, he would explain it to us all when we came in. And of course, like any good parent, we become Dr. Google that day. She did.
Some of what we read about mobility and life expectancy really did scare us. We know everybody's different, but when it's your child, you can't help it. Your mind goes there immediately. About a week later, I got the call from the geneticist that we needed to come in. He was right about her diagnosis. After meeting with him, we were still scared but relieved to have some answers. He broke down SLO in a way that was easy to understand, explaining how you have good and bad cholesterol, and kids with SLO often produce too much bad and not enough good. He started her on her cholesterol supplement, which seemed to help her cholesterol levels, and we saw some improvement in her overall function.
A few months later, we were on a social media page for parents with kids with SOLS. When we read about Cholbam, a cholic acid capsule, Taylor and I were interested to learn more. Mally had an appointment coming up the next week with her geneticist, so we agreed to ask him about it. When we saw him, he spent some time playing with Mally, like always, before we even get to talk to him. He said, "There's something I want to ask you all about, and there's this treatment called Cholbam. I think it would help Mally. Would you like to try it?" That felt like a sign. We talked about the possible side effects, including diarrhea. He then told us that they would watch for side effects and monitor her blood work regularly. And if we didn't like what we saw, we could take her off of it.
Of course, we were a little scared of possible side effects, but we were more excited for the possibilities of how it could help. And we trust the geneticist and know that he has Mally's best interests at heart, so we decided to try it. I know everyone reacts to medicines differently, and Cholbam may not work for everybody, but for us, it was the best decision we can make for Mally. Since we added Cholbam into Mally's SLOS treatment in 2023, we've seen consistent improvements in her cholesterol levels and her height and weight. Mally's geneticist is diligent about making sure we have lab work done regularly. That includes cholesterol levels, liver function, and liver enzymes to make sure Mally's levels are where they need to be. Mally did experience some diarrhea for about a week when she started Cholbam, but it did resolve, and she hasn't had any additional side effects since then. That's just our experience, and like you said, everyone is different. We settled into a good routine with Mally. She goes to physical therapy, occupational therapy, and speech 3 times a week, which she's done since she was 4 months old. Her feeding schedule is different and a little more complex. We do bolus and syringe feeding, and we also feed her by mouth. She does have a tiny mouth like all of them, so it's still just purees. But she's eating more now, and we've made a routine to make it as simple as possible. And we built her treatment into the routine. She takes her medications first thing in the morning with her feeding, and then again at night during her feeding. Even though things are better, caring for a kid with SLO is still a lot of work, as y'all know. But just like we always have, James and I have been there to support each other. I went to work part-time so I could give her more one-on-one time and to be her full-time caregiver. James gets up at work at 5 on a good day, but gets home at work at 2:30, so he comes home and helps.
I know Taylor handles most of the work because she's at home with her every day. When I get home, I get the fun side where I can play with Mally, and then my favorite, take naps with her. But when I get home, I'm helping with things throughout the day, like diaper changes, feeding, and anything else Taylor needs. And I'm there for Taylor if she ever needs someone to vent to or just to let some stress out. That's important because you have to take life with SOLS from day to day. You don't know what you're going to get with Mally or what mood you will be in, or she will be in for sure. I know that this is the same with every kid, but even more with SOLS. Luckily, her doctor is always there and willing to take Taylor's messages no matter when it is.
Today, Mally is doing well. You can hear her right now squealing. She's still on the G-tube to make sure she's getting all the nutrients she needs, and she still isn't eating a ton most of the days. But her appetite is getting better, and now she really wants to eat orally. She started gaining weight and is getting a little taller. She started walking when she was around 3.5 years old. She's participating in therapy more and seems to be engaging more as well.
For us, every small victory is a huge one. Her language has been one of the big ones for me. She started saying a few words when she was around 2, but they were just random words. Recently, she started identifying objects like an apple or a car. That's a big milestone for us.
We know Mally has her challenges, but we try to make everything as normal as possible for her. We want her to dance and play sports as she wants to. We want her to go to school one day. We think we're going to homeschool her first year and just see how she does, but then put her in school if we can. If she shows interest in something, we want to let her do it. We don't hold her back because of her disabilities, and that's how we'll continue to raise her. I know she'll have adjustments throughout her life, but we'll keep doing what we can to give her that normal life.
If I could leave you with just one thing, remember life with SOLS is like stepping stones over a river. You have to take one of them at a time. I know Mally's life will look a little different than, Mally's normal life will look a little different than ours, but parents like us can make it as normal as possible. Please understand, it's not the end of the world, and take every day with patience. That was a hard one for me, but you have to strive to take it day by day and be better. Remember, these kids come with lots of love.
I would just encourage you to talk to your healthcare team to see if cold balm is right for your child. I know every family is different and it won't work for everybody, but we've had a positive experience since we added cold balm into her treatment, and I want everyone to have the opportunity to talk to their doctor to see if it can be right for them. Finally, I just want to say we are forever thankful for the doctors and the one that's here and that care for our baby and for the medicine and research that got us here. Thank you.
Thank you.
Oh no. No question and answer.
Great job, guys. That was amazing. Oh my gosh. So we're going to have some Q&A time. And so I don't know if anyone has a card or wants to come up. And Dr. Farron is obviously here. I don't know if Dr. Joe Ray is still on for questions as well. But I'll kind of kick it off. And then if you have a question, we can come to you. So I just want to ask you guys first, like, why you felt it's important to tell your story and share it in this way. I know this is the first time you've done this, and it's kind of new and different, and why it matters to you.
I think it's important because, you can read all you want online, but it just doesn't seem like real life. But when you hear from a family and you see the family and how it's had a positive impact on them, like, it just makes it seem, I guess, more sense, to try it. So I just think that's how I feel.
Any
Do you know how low her cholesterol was when you started?
Dr. Farron might know that. I don't remember.
The question is, do we know how low the cholesterol was when she started?
We were around 100 when we started with true cholesterol.
We were on cold balm for a while, and our liver numbers never regulated, and we were with we had our pediatrician, the liver specialist, and a GI doctor all involved. And funny enough, we're at Levine's, and I didn't know until I saw you were coming here, so I'm like, oh, maybe we need to go see a geneticist. First of all, is that recommended to have a geneticist who would kind of be in charge of all of that? Because we haven't been to genetics in a while. I mean, it's been probably 8 years. Ours actually retired, and it was a travel situation, but is that something that's more recommended to have a geneticist supervise all of that?
Yeah, I've got this one, Joe. I know me and you have talked about this numerous times.
Sure.
I think so. I think there's been a lot of changes with genetics. I think is initially was more viewed as a diagnostic place where you would go and get a diagnostic, and I think over time it's also now become more of a treatment specialty as well. And so, I mean, we'd be more than happy to. I know my partner and I, who treat SLOS, have been there about 5 years now. And so we'd be more than happy to kind of be that home base for things as we get started. But yeah, I think it's just been kind of a change in the way the specialty is viewed over the last few years.
What would be the expectation of cholesterol levels? I mean, is there like for them to be raised on the Cobam, or because I'm just curious, or is it just different?
That would be my hope. I think we've talked a lot about how this can affect patients differently, and we're still learning a lot because we haven't had that many patients on the medication yet. But my hope would be that we would be able to raise cholesterol and improve growth, and that's where I would like to start with my goals.
And this might be not in the plans, but as a person involved in research, I remember when Dr. Steiner said, well, we just need you to give up cholesterol for 6 months so we can, and I'm like, no way. And so we were just talking about the similarities, and my boys are 22 and 18, so like will you be able to get a study where you have a control group that won't use and will use, so you can really, I mean, only because what's attributed to what is hard to figure out as they grow.
Yeah, you want to go there?
Come on.
And so I do agree. It's difficult to get that study because the standard of treatment right now is to go ahead and be on cholesterol supplementation, and I think it would be difficult to. And also, what I don't see this being as big a benefit without the cholesterol supplementation, because we're looking for the improved absorption in the gut with the bile acid supplementation. And so I do think they have to run together, which does make it difficult to see what's providing the benefit and which one is more responsible.
I think that's something really, really important to clarify. You can't see me over there on the screen, but this is Ellen Elias. So cholesterol given all by itself is not the idea with this disease. You're giving it to help the body better absorb the cholesterol that the patient needs. So you would not need to go off cholesterol while you're taking Cobam. The reason I asked the question about your daughter and how low her cholesterol level was when you first started is that if the cholesterol level is high enough, then the child can make their own bile acids. And the question of whether you should check bile acids first before you start the Cobam, I thought was an extremely intelligent question. Because if a child really has bile acid deficiency, then taking bile acids would clearly help. You know, one of the questions that I have personally in my mind is if you're one of those mild patients with SLO whose cholesterol levels are high enough so you can make your own bile acids, would it be helpful in those patients? And in that situation, the jury is still out, I think.
Yes. Ellen and I did the study, the short-term study that a lot of this is based on, and there was a wide range of cholesterol intake by those patients. One of them was not on cholesterol supplementation specifically. And when we plotted the data looking at the cholesterol intake versus the response to cholic acid, Cobam, there was not a really good relationship at all. So the numbers were low, 12 subjects in the study. The time that we treated them was short, 2 months. But at that point, we could not demonstrate anything with respect to the relationship between the amount of cholesterol taken in and the response. That said, they had a wide range of dietary intake of cholesterol, the response, I think, might be related to that as well. We just don't know at this point in time. That's why it's important to do a follow-up study. And the hope is that we will do a longer study than we did initially, in that we would monitor bile acids along with oxysterols and cholesterol levels, et cetera, along with weight gain over time, as well as height and so on, just to see whether or not this has a sustained effect, and also whether or not it really is beneficial from at least a biochemical point of view, and hopefully we can get some kind of behavioral information from that study. So I would look forward to that. We will do something with Miriam. Miriam's going to be funding something like this, and we'll just see where things stand. We hope to have a control group, in a sense, that is not taking Cholbam, but is taking cholesterol, to compare, at least for a period of time, whether or not the Cholbam by itself adds more weight to the patients and gives them a better response from a biochemical point of view. So yeah, the question about whether or not you have to supplement with cholesterol is really kind of still up in the air. But I would say that we all get cholesterol in our diet, no matter what we're eating, and perhaps that can benefit it as well.
Another question from the back.
So both my boys are on synthetic cholesterol. So I'm wondering, because we're not on this Cholbam, but I've talked to the people, would it be more beneficial for it to be together, or would it be more beneficial to potentially get into a case study where they're just taking cholesterol to see the difference?
You want that one, Joe, or you want me to keep going?
Can you repeat the question one more time for me?
So both my boys are on synthetic cholesterol made with almond oil. Would it be better for them to just go onto this Cholbam, or would it be better to try to get into a research study just with them being on cholesterol and not this medicine?
I don't think they need to be in a research study to try Cholbam. I mean, we have a label for prescribing this medication to patients that qualify for it. And there is no segregation based off of being on synthetic cholesterol versus egg yolks. The patients that were in the Elias trial that I discussed earlier, those 12 patients, they were on a mix between synthetic cholesterol and egg yolks. And we saw similar responses in both scenarios. So I don't think that needs to be a consideration when deciding whether or not to try Cholbam.
Another question? You have some? Can you just give the families an idea of what kind of lab work is involved? Because I know that when we talked about it, it was quite frequent, which would be very limiting to us, especially working parents.
Yeah, it was a lot of liver function monitoring in general sense. It is frequent, I'll admit. We started off every 3 months, if I remember correctly, and then have spaced out over time as we've gotten things into a really good steady state. I think that's something, though. We have families that come from very, very far away to come see us. I think if you can find a good home, that'd be something that maybe you could get the labs done on your time, but also at a closer location, because they're not for the most part, other than the cholesterol metabolites, they're not that difficult of a lab, like a regular lab should be able to accomplish that.
I'll ask the Weavers, what did you think about that as far as just the being able to do labs and your impression at once starting Cobom, of what you felt?
I mean, it was pretty frequent, but I mean, y'all know how difficult all the kids are. I think that's the most stressful part, but like it just made you feel better to have the lab work done so frequently, because just to check your liver enzymes and stuff like that. So I'd say it was worth it. I wouldn't want to go any more than 3 to 4 months, just being honest. But and I wouldn't want to go even farther apart. Like I wouldn't want to go like every 6 months. I want to keep a good track of it to make sure she's okay taking the medicine.
And just kind of back to those questions. What I know you mentioned when this was presented to you. What do you think made you feel comfortable to kind of start Cobom, or what that was that was clear to you that this was right?
I think a big part of it was talking to Dr. Farron. He just made us feel comfortable. Like I said, we're going to keep a check on her regularly, every 2 to 3 months, I think it was. Oh, and there's Mally.
Mally wants to tell us about it. Say hi to your people, Mally.
Hey, baby. Just knowing that like they were going to keep a check on her lab works or whatever. Made us feel more comfortable, and he told us like if things aren't going right, we're going to take her off of it. Like that's all there is to it. So that just made us feel better, and we knew that we'd see good results.
I'd like to say something about the liver disease, or the concern over liver disease in this SLOS and Cobom. Cobom was originally approved by the FDA for defects in bile acid synthesis. These are babies, usually babies, that already have significant liver disease at the time they're first diagnosed. And sometimes the liver disease progresses on a natural basis as opposed to use of Cobom. Cobom was then used also and approved by the FDA for a group of diseases called peroxisomal disorders. And those patients also had underlying liver disease to begin with. And some of them did show worsening of liver disease on the drug itself. Now, when we originally designed this study, this short-term study, we took into account that the approved dose for Cobom was 15 milligrams per kilogram, but there was no real good data on SLOS patients at that time. So we decided to back off a little bit on the dose and treat patients with 10 milligrams per kilogram. Okay? And that dose, we found no evidence of liver disease in the 12 patients that we treated for the 2 months. We monitored them as far as their liver function tests throughout the study. And I am, based on that, and also probably some anecdotal data as well, I'm not too concerned about liver disease in SLOS, frankly. I don't think Cobom is going to give much of a detrimental effect, let's say, on the function of the liver. We have not seen it so far. And I suspect that if there are changes in liver function tests, they can be monitored, certainly. But it's not a kind of a test that I'm so concerned about with SLOS patients that I would do testing, let's say, every two months or so even. Maybe initially when you start on it, but beyond that, I don't think it needs to be monitored as closely as some people are commenting about.
One of the tricky things I was wondering if you came up, Dr. Farron, with any other ways to get around this, but Cobom only comes as capsules. There are 2 different sizes of the capsules, and so some people can swallow capsules, but most of my patients with SLO, you have to open up the capsule and add it to whatever the child is eating or to their G-tube feeds if that's how they're fed. So one of the things that would really be awesome is if there could be developed a liquid form of this medication that was easy to find and to administer. So we did that in Colorado, worked with my pharmacist, and we figured out a way to open up the capsules and put them in to water and have it be in a dose. We taught the parents how to make the exact dose that the kid needed based on the child's weight. I think if this medicine could be given to much smaller children, more severe children, it would be wonderful if there was a way that Miriam could figure out a liquid preparation of this, it would just make it so much easier.
I mean, yeah, completely agree. It would be great, especially with some of we're picking up some of the paroxysmal disorders now on newborn screening with the XALD introduction. So being able to administer it liquid would be great. So if you can hear me back there, Jeff.
Great. Oh, you want to? Yeah. Let me. I'm running.
Obviously, right now you can open up the capsules, and as we know, a lot of the children have the G tube already that you can obviously put it in the G tube. But we are constantly exploring new opportunities to make sure this can get to as many patients as possible. So I'll leave it at that.
I think we have maybe one more minute if there's a final question. Great. Can we give a huge round of applause for the Weavers, Dr. Farron and Dr. Joe Ray? Thank you so much. I think some of you have mentioned that your child is on Cholbam and you'd want to share about that. You can scan this QR code. We'd just love to hear your story. Just like the Weavers, we love to hear family stories. So feel free to go to the website. And also we have the table there, so there's more information. And if you're online, you can go to cholbam.com. So that is all, and I'll pass it on.